Good day to everyone, and welcome to this webinar. My name is Dr. Tom Madayag, and our topic of presentation for today is respiratory assessment and lung sounds. Before we begin, I'd like to ask you this question. If I were to give you 10 lung sounds, how many will you be able to identify? Please select one. Okay. All right. Well, thank you very much for responding to that, Paul. And this is our skill level at this point. And so some of you are experts and some of you are beginning as far as lung sounds are concerned. Lung sounds is a very important part or component of physical assessment. And I think this is one of the least developed skills among nurses because of the fact that it could be a confusing thing. And that's the reason why this is included in this webinar. During your orientation here in the United States, they usually ask you to demonstrate your skills in physical assessment. And one of the things that we observe among international nurses is the lack of consistency as far as the identification of breath sounds and lung sounds. And that is the reason why we embark on this particular educational endeavor in order for us to be able to hone in on those skills. So I'd like to begin our discussion with the equipment which we use to perform this part of the assessment, and that is the stethoscope. I know that each one of you has one. I realize that you have been using a stethoscope for a while, but my experience with practicing clinicians is that not all understand how to maximize the use of this particular equipment. So whenever we have a stethoscope, there is the diaphragm and the bell, and you all know that. Most stethoscopes have two elements to the chest piece, as I said, the diaphragm and the bell. And the diaphragm, which is this particular component of the stethoscope, is going to be the one that is used to listen for high frequency sounds, while the bell, this particular piece right here, picks up lower frequencies. Now, on some models, these are on opposite sides, requiring the chest piece to be rotated to switch between the two. And there's also another one that only has one particular component right here. It is both a diaphragm and a bell. When you press on it, it's going to be a diaphragm. And when you lightly put pressure on the piece, it becomes a bell. So depending on what you're listening for, the stethoscope should be placed against different points on the body. And ideally, it should always be against the skin, because even a thin layer of clothing will impede the performance. So there's also another thing that when applied firmly against the patient's skin, the diaphragm is able to transmit high frequency sounds. And this is going to be very important. The pressure should be enough to create an indention or a mark in the skin. If you use the diaphragm without the skin indention or marking, then it means to say that you haven't pressed it enough. Conversely, when you use the bell being the one that transmits low frequency sounds, should be applied very lightly. Pressing more firmly with the bell can stretch the underlying skin and essentially, therefore, turning it into a diaphragm. So make sure that you know the difference between the two, okay? So diaphragm, it should be firm application against the skin, enough to create a skin indentation or marking. The bell should only be lightly held or applied to the skin enough to occlude the ambient environment so that you're only listening to the body part that you have applied the bell onto. All right, I have another poll right over here. All right, when wearing a stethoscope, the earpieces should be pointing to which way? All right, thank you. All right, let's see. Let me share with you the results, okay? So some of you said towards the nose, some of you towards the back, and some of you said either way. Now, I've spent most of my time actually teaching physical assessment, and I found out actually that not all nurses know how to use the stethoscope, and that's the truth. Now, I also taught in India for 3 years, and part of my responsibility in India was to establish a simulation center. And I noticed that in the rotation of nurses coming into the simulation center, some of them actually do not know how to use the stethoscope as well. The same thing in the simulation centers here in the United States. So when we get nurses from the international arena, they have to go to a simulation center and they demonstrate physical assessment skills. And one of the things that we notice is that it is inconsistent as far as the demonstration for the proper way of the use of a stethoscope. And that is the reason why we have this particular educational endeavor in order to rectify that. Okay, so there is a right way and a wrong way to wear a stethoscope. Starting from the top of the stethoscope, the earpieces should be inserted so that they point towards the bridge of your nose, okay? So in order to be able to hear appropriately, you should have the earpieces pointing towards your nose. This is because your ear canals are angled slightly forward. You'll know that you have a good fit because all the noise around you becomes very faint when the earpieces are inserted, allowing you to concentrate on the sounds coming through the stethoscope. All right. So there are several things that we need to also emphasize as far as the use of the stethoscope is concerned, is that another useful guide is to hold the stethoscope headset in front of you, of your face, and see whether you can see the holes in the earpieces. If you can, again, it's the wrong way around because the earpieces should face slightly away from you. Okay. So let's move forward. There are several things that I'd like to emphasize at the outset as far as the use of the stethoscope are concerned. And these are the common errors that have been identified and observed among people that are doing client assessment. Number one, listening to breath sounds through a patient's gown or clothes is a no-no. It distracts the intensity of those sounds and should be avoided at all costs. Secondly, when we allow the tubing to rub against the bed rails or the patient's clothes, this creates an artifact and therefore it should be avoided. The stethoscope should be straight, stretched all the way to its length in order to prevent it rubbing against the patient's skin or clothes or the bed rails. Third is to interpret chest sounds as adventitious sounds because of the presence and the friction that is caused by chest hair. So this is a challenge, particularly when you're auscultating a very hairy chest. And one of the suggestions that is actually given in order to prevent the artifact from occurring is to press the diaphragm firmly. And in addition to that, another strategy in order to prevent the amplification of artifact is to wet the hair. And obviously, this is an impractical thing when you're doing physical assessment on a patient. But if you can use an alcohol swab, for example, and apply that alcohol swab in the area where you're auscultating, that would diminish the possibility of the transmission of artifact. And of course, auscultating on convenient places only. So we will learn the areas that are minimal for you to auscultate on patients who are going to be your subject for your client assessment. All right. So having laid that aside, let's now go to the anatomical considerations and the landmarks for auscultation. And the reason we begin with this is because of the fact that if you imagine the anatomical structure upon which your stethoscope is laid upon, then you will have a better understanding of what is normal and what is abnormal. So breath sounds are produced in the major airways. The trachea, which is this one right over here. And of course, the periphery and the major bronchi. So whenever you are auscultating, always think of the underlying anatomical structure so that you can relate the findings to a possible pathology. And therefore, this is going to be important. Now, I want to emphasize something. It is a common misconception, by the way, that the alveoli, the air going into the alveoli, produces these sounds. So this is a misconception. They do not. The velocity of air in the alveoli is not significant enough to create turbulence and audible sounds of auscultation. So what you're listening to is actually the entry and exit of air in the major or larger structures of the respiratory tract. So going back to anatomy, we have two lungs. I don't want to insult your intelligence, but this is just in order to emphasize the point. We have two lungs, and the right lung, which is going to be divided into three main lobes right over here. As you could see, there are three lobes. And they are separated by these structures right over here. And they are called the horizontal as well as the oblique fissures. And these lobes are the superior lobe, the middle lobe, as well as the inferior lobe. The left lung right over here is separated by the oblique fissure. This is the fissure right here. And it has two main lobes, the superior as well as the inferior lobe. Understanding the pulmonary exam is enhanced by obviously, again, recognizing the relationships between the surface structures, the skeleton, and the main lobes of the lung. So when we look at it posteriorly, notice now that we have a better capture as far as the anatomical considerations of the lung. You have a better way to appreciate lung sounds. And that is why for beginning or beginner students, we always encourage them to do the pulmonary assessment starting from the back first in order to have an unimpeded and pure sound coming from the lungs. So the reason for that, as you could see over here, is you have a greater lung mass compared to the anterior component, which is going to be, of course, obstructed by the presence of the heart. So this is a further illustration of the lobes of the lungs, both anteriorly and posteriorly. And of course, lung examination or respiratory assessment cannot be complete without including the lateral surfaces. So these are the lateral surfaces that you will see on the side. Is going to be on the right side, illustrating where the right middle lobe, the right lower lobe, and the right upper lobe is. And then, of course, on the left side, the left upper lobe and the left lower lobe. Okay, so let's go further and let me ask you a question. All right, if you're listening to somebody's chest and you put your stethoscope to where that arrow is, what sound are you going to likely hear? How about the others? Okay, thank you very much for participating. And this is how you all responded before we discuss. Okay, so whenever we're listening to the lung sounds, we have to make sure that we understand, again, what anatomical structures are underneath your stethoscope. Right over this area is the scapulae, right? And the scapulae is a thick bone, and therefore it will not be able to transmit breath sounds to your ears. So the correct answer to that question is you will not hear anything. And so one of the key things that when we assess students in the simulation center to determine whether or not they really know how to auscultate breath sounds is we observe whether or not they put their stethoscopes in this area. This area should always be avoided because there are no sounds that are going to be transmitted over bone. So these areas over the scapulae are supposed to be omitted in performing a posterior lung assessment. Okay, so please make sure that you remember that when we listen to breath sounds, we only try to access those parts of the lungs that are not covered by bone, by a big bone, I should say, and a thick bone. All right, so let's move on and go on then to lung sounds or respiratory sounds. So when we're talking about lung sounds, there are two types of lung sounds. One is normal breath sounds, and the other one is abnormal, also known as adventitious breath sounds. So lung sounds or breath sounds can be auscultated across the anterior as well as the posterior chest walls with your stethoscope. So in this section, we will discuss normal and abnormal breath sounds, also called adventitious breath sounds. So when we listen to lung sounds, obviously we could listen to it according to the phase during inspiration, and we call that the inspiratory cycle, or expiration, we call that the expiratory phase. However, there are two types of sounds that we would like to appreciate when we are listening to breath sounds, normal breath sounds. And the first one is what's called bronchial breath sound or tubular breath sound. And the other one is called vesicular breath sounds. So what's the difference between the two? So let us see. As I said, normal breath sounds are of two kinds, the bronchial breath sound and the vesicular breath sound. Let's begin with a normal breath sound, which is the bronchial breath sound. So what is a bronchial breath sound? A bronchial breath sound is a sound that emanates from the major airways. So the reason I have to find a piece of paper is because the trachea is likened to a rolled piece of paper. And you see me now, I hope, with this rolled paper. And when I talk to this rolled paper, do you notice a distinct difference in the transmission of the sound? You do. This is what is known as a tubular or a bronchial breath sound. And again, relating it to the anatomical structures, anything, therefore, from the neck all the way to the second intercostal space is going to be a distinct sound that is tubular in nature. So this is what is known as a bronchial sound. So let us begin analyzing what a bronchial breath sound is. Bronchial breath sounds are usually loud. They are high pitch and they sound very close to the stethoscope. The character of the sound is hollow. And more importantly, there is a gap between the inspiratory and the expiratory phases of respiration, and the expiratory sounds are almost equal to the length of the inspiratory sounds. So let me just go back to this particular slide right over here to illustrate that whenever you're listening to a bronchial breath sound, remember that there is going to be a gap between inspiration and expiration. So there is this gap. You hear this right there, and then right there. In contrast to another sound called vesicular breath sounds, wherein there's no gap at all. Okay? So always remember that when you listen to, I should say, bronchial breath sounds, there is going to be an intense inspiratory component with a break, and then an expiratory component. Notice that the length of the inspiration and the expiration are almost the same. Okay? All right. So let me summarize that the best way, therefore, to recognize bronchial breath sounds while performing auscultation is to look for the hollow character of that sound. Then confirm that it is indeed bronchial breathing by looking for the gap between inspiration and expiration and the equality of these two phases of respirations. So let me go back to this slide to ask you a question. This sound is normal only when it's found in these areas, therefore. If you hear bronchial breath sounds in the periphery where they do not belong, then that means to say that there is going to be an abnormality. When do lung sounds become louder? Is it when the lungs become solid, such as when you have pneumonia and the alveoli become solidified, and we call that consolidation? Or is it because when they're air-filled? Which one will be louder? And the answer to that is lung sounds will be louder if they occur in an area that is solid. Solidification amplifies the sounds. Thus, when you hear bronchial breath sounds right over here or over here in the periphery, that means to say that that area is solidified. Solidification is what is known as consolidation. So you now have a blank screen, and that is intentional because I wanted to illustrate to you what usually happens whenever we have consolidation. So, whenever we have a healthy lung, and let's say this is the bronchioles and these are the alveoli, right? They are separated. But let's say now that because of collapse, the alveoli is no longer air-filled. Oh, sorry about that. It's not cooperating. And these become solid. Therefore, what happens is sounds are going to be transmitted much more forcefully and louder. And therefore, it becomes a bronchial breath sound. Okay, so let's see. Oops. What happened? Just one moment. Okay. I lost my view. Okay. What happened over here? Just one moment. There you go. Okay. Nonetheless, we'll go ahead and move forward. Okay. So this is what happened. Okay, so those were the bronchial breath sounds. Again, if you heard these sounds over the other areas other than the areas that we had indicated, then that means to say that there might be consolidation. There could also be a possibility that there is a cavitation in that area. And sometimes this might be a manifestation of fibrosis and upper lobe collapse. All right. Thank you, Francisca. Francisca didn't get that, so let me just go back and rediscuss it. Okay. So if this sounds that you normally hear over on this area is present over here on these areas, what had happened? Okay, which one would transmit sounds better to a stethoscope? Is it sounds transmitted by air or sounds transmitted by a solid mass? Okay, so this is true air and this is true solid mass. Which one would be louder? Hello? Solids, right?
Solid mass.
So therefore, when you put your stethoscope and you are anticipating the sounds to be from an air-filled structure, but now it is through a solid mass, then that means to say that it is safe to assume that there is solidification in that area, and solidification in lung tissue is what is known as consolidation. Such is what is present when your alveoli collapses. And in cases of collapse, such as what happens in pneumonia, you therefore have an amplification of that sound. Okay? So that is going to be the reason why the sounds are going to be much more intense. Okay? So that is a bronchial breath sound. So we're now going to listen to a bronchial breath sound. Notice now that there is going to be a break in between, okay? And the inspiratory cycle and the expiratory cycle is almost going to be similar. So let us listen to a bronchial breath sound. All right, were you able to hear that well? Did you hear the gap in between inspiration and expiration? No? Okay. Hold on one moment then. If you did not hear it well, let's do some optional thing here and let's see. Let's go to Hold on. Can you hear that now?
Yes.
Okay. So let's Okay. So were you able to appreciate the gap between the
Yes.
inspiratory phase and the expiratory phase? Yes?
Yes.
Okay,
Yeah.
great. Thank you. All right, let's move on to our presentation over here. See. Okay, so that was bronchial breath sounds. Now, as a review, I wanted to emphasize the following then. That when you're auscultating anteriorly, as you could see in the areas marked B, these are all going to be what is the areas that you will be able to appreciate the bronchial breath sounds, also known as bronchovesicular breath sounds. Now, the reason why you don't see any hold on one moment. There's some sound that's interrupting. Anyway, whenever you are looking over here, putting your stethoscope right over here, you will not be able to hear the sound. Why is it that you don't hear anything right over in the center? Hello? Because this is going to be the sternum, isn't it? So therefore, you will not be able to appreciate. But you could hear something at the side of it, and we'll talk about that in a little bit. Okay, so that is the anterior component of it. And when we go to the posterior, right over here, there's going to be no bronchial breath sounds that you will appreciate because these are all over bone. Okay? All right. So let's go on now to another sound, which is vesicular breath sounds. Let's skip the bronchovesicular first. I'm going to go to vesicular breath sounds next. All right. So vesicular breath sounds are sounds that is a normal breath sound, and it is heard over most of the lung fields during auscultation. It is soft and low pitched or low frequency. And the expiratory phase is shorter. As you could see, this is the expiratory phase. This is the inspiratory phase. it is much shorter than the inspiratory phase. So the expiratory phase is shorter because the breath sounds that are produced in the latter 2/3 of expiration are mainly composed of high-pitched sounds which are filtered out. So when you're listening to vesicular breath sounds, they are similar in character to the rustling of dry leaves. In fact, Lanak, who is the inventor of the stethoscope, coined the term vesicular breath sounds. He named it due to his belief that the air flowing through the alveoli produce these sounds. We now know that these sounds are actually not produced by entry and exit of air in the alveoli. So, as we have said, it is a misnomer. Okay? So, these are the characteristics of vesicular breath sounds. The pitch is high, they're quiet, and of course, you're going to be able to appreciate them in the periphery. Okay, so in the periphery. So again, over here, as you could see, I'm going now to zoom in. The vesicular breath sounds are those indicated with a V anteriorly right over here. And of course, posteriorly, right over in this area is going to be the areas where you could appreciate vesicular breath sounds. So again, it underscores, this illustration underscores the fact that you cannot hear anything. What happened?
Hello and welcome to Simple Nursing Breath Sounds Made.
Hold on one moment. Something is playing in the background, and I think that's the... Sorry about that. So let's listen to what a vesicular breath sounds sound like. And I'm going to share again this screen. Okay, so one moment. I'm going to share my screen again. Okay, so that was the vesicular breath sounds. And as you have noticed, the expiratory phase is going to be quieter compared to the inspiratory phase. Okay, So let's go back to my presentation. Okay, so the areas wherein you're going to hear the vesicular breath sounds, as I said, are in the periphery. So let's go on to the next sound, and they are going to be your bronchovesicular breath sounds. And I needed to go back to that because of the fact that basically there are only two types of breath sounds, vesicular and bronchial breath sounds. However, the intermediate combination of the two is what is known as the bronchovesicular breath sounds. So bronchovesicular breath sounds are therefore going to be heard in areas wherein the anatomical structure combines both bronchial and vesicular components. As you could see in this particular slide, right over here is the proximity of the bronchial sounds and the vesicular breath sounds. So the combination will be known as bronchovesicular. So what are the characteristics of a bronchovesicular breath sounds? Bronchovesicular breath sounds are going to be a blowing sound heard over the airways on either side of the sternum, at the angle of Louis, and between the scapulae. So again, similar to bronchial breath sounds, they would be abnormal if you hear them in areas where vesicular breath sounds are supposed to be. They differ from bronchial breath sounds in the sense that they do not have a gap in between. Okay, so when you hear a gap in between, that's a bronchial breath sounds. When there is no gap in between, then this is what is known as a bronchovesicular breath sound. So again, let's go ahead and listen to a bronchial breath sound. I hear a baby. Hold on one moment. Let me just mute everyone. Okay. All right, let's go ahead and listen to a bronchovesicular breath sounds. Let me just share my screen. Okay, so that's bronchovesicular breath sounds. So we now have finished all the normal breath sounds, namely we had bronchial breath sound, vesicular breath sounds, and then of course we have a combination of the two, and that is bronchovesicular breath sounds. So let's go back to our presentation. because now we're going to go to a discussion of abnormal breath sounds. All right, I think this is a nice point for me to pause to see if you have any questions at this time. None? Okay, so let's go on to abnormal breath sounds, also known as adventitious sounds. These refer to those that are heard in addition to expected breath sounds. These sounds are usually superimposed on normal breath sounds, and they are characterized by differing intensity, different duration, or different quality when compared to those of the normal respiratory sounds. So when they're present, they're most likely due to pathology. Now, to decrease confusion, the International Lung Sounds Association in 1985 divided adventitious sounds into two categories. One, a continuous sound, and the second one, discontinuous sounds. And the difference between the two is exactly its definition. So when I say, here is a sound, notice that there's no break in between. But when a sound is, notice that there's distinct pause or a distinct discontinuation of those sounds. So continuous sounds are going to be those that are uninterrupted, and discontinuous sounds are those that are going to be interrupted. So when we are looking at discontinuous sounds, they include your crackles, and you could also have the pleural friction rub. And for continuous sounds, we have what is known as a wheeze or a rhonchi. So whenever we are going to be describing these sounds, we are going to describe the timing of the sounds in the respiratory cycle, such as, is it occurring during inspiration, or is it on expiration, or is it in both? We also should include where they're located and whether they clear with coughing. This is very important. If you listen to a sound which clears with coughing, then that means to say that it is a temporary observation. But if it doesn't clear with coughing, then that means to say that it's highly pathologic. Okay? Another thing that you would need to evaluate is pitch. Pitch is also a very important thing to include in observation of breath sounds, as they are very telling of what kind of abnormality is present. Wheezes and fine crackles are high pitch, for example, whereas rhonchi and coarse crackles are usually low pitch. So let us go on and discuss the first adventitious breath sound, and that is what is called rhoncha, rhonchus, or rhonchi. So what is rhonchi? Rhonchi is produced by the fluttering of narrowed airways and the air that flows through them. So there are continuous sounds, musical sounds, and there are of two kinds. One is what's high pitch, and the other one is what is low pitch. So whenever we listen to a sound that is a continuous sound, and it's low pitch, then this is referred to as a sonorous bronchi. Sonorous comes from the word snore, or snore comes from the word sonorous. And we could just imagine how that sounds then. So I'm going to illustrate with my voice whether or not you can distinguish high pitch versus low pitch. So if the sound is ooh, ooh, versus ee, 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 which one was low pitch? The first one or the second one?
The first one.
The first one. Okay. So whenever you hear a continuous sound that is low pitch, we call that bronchi. A high pitch bronchi is what is known as a wheeze. So remember now, when you are going to, here in the United States, we have a bad habit of saying, the patient has bronchi. Now, when you hear that, it is assumed that it is a low-pitch bronchi. If it is a high-pitch bronchi, we say the patient has a wheeze. They're one and the same thing, okay? But the first one, a low pitch, is low pitch because it indicates that there is secretions in the airway, in the larger airway. When there is a high pitch, also known as a sibilant bronchi, then there is, in addition to that, narrowing of the airway. Okay? So those are the main differences. So an auscultation, when we say that there is a sonorous bronchi, there is going to be a low pitch. So bronchi is mainly caused by either the accumulation of secretions, or it could be a lesion or foreign body. And they're common in common findings in pneumonia, in chronic bronchitis, as well as cystic fibrosis. So let us listen to a bronchi. Let's go back to YouTube again because you are not able to
When Memorial and Holy Cross chose to partner with Oscar for Medicare Advantage, I was all for it. Oscar's in touch with my doctors, and their care team helps me figure out my meds. No more hassles for this guy.
A Medicare Advantage partnership that works for you.
Okay, so when you hear these sounds, that means to say that there are secretions in the major airway. For unconscious patients, this is our signal that we need to suction the patient. For patients that are conscious, we need to encourage them to cough and deep breathe so that this could be rectified. So that is a sonorous rhonchi. So let's now go to the sibilant rhonchi or wheeze. Okay, so that is a wheeze. So we have now talked about the continuous adventitious breath sounds. So again, there are two of them. One is sonorous rhonchi, also referred to as just plain rhonchi. And the other one is sibilant rhonchi, which is high pitch. And this is going to be a continuous musical sound of a high pitch quality, which represents a narrowing of the airway. So at this juncture, what I'd like to do is to now have a 5-minute break. So if you don't mind, let's just go ahead and take a 5-minute break, and then we will discuss the next abnormalities or abnormal breath sounds. And they are the discontinuous sounds. Okay, so let's have 5 minutes. Let me just put on the timer. And share the screen. Okay, so let's go for 5 minutes. Okay, welcome back, everyone. And we're going to go ahead and continue with our discussion. So let me just go back to our slide over here. Share. Screen number 2, share. And we're going to do this. Okay, so that was Ronkai that we had talked about and their continuous breath sounds. So let's now go to discussion of the other one, which is also known as the wheeze. We already did that. So let's go to discontinuous breath sounds. So when I say, those are discontinuous because there are breaks in between. And that's exactly what we're going to be talking about now as far as these sounds are concerned. So another type of adventitious breath sounds are rowels, also known as crackles or crepitations, depending on where you are. Here in the United States, we often refer to these as rowels rather than crackles. So these sounds are described as discontinuous sounds because the sounds have breaks in between, and they can be described as popping sounds that originate in the airways. In fact, the crackles are generated by small airways snapping open on inspiration, and therefore they are predominantly inspiratory. Crackles and ralphs usually imply that there is an accumulation of secretions or fluid or exudate within the airways or inflammation and edema in the pulmonary tissue. So there are two types of crackles, and actually there's not any importance at all to distinguishing the two. A rowl is a rowl or a crackle is a crackle. But fine crackles and coarse crackles have been actually been differentiated. And the difference between the two is believed to come from the size of the airway that is snapping. Larger airways have a deeper pitch and therefore create coarse crackles. So as I said, crackles are going to be often associated with lung inflammation or infection. If they do not clear after a cough, this therefore is very significant because it is an indication that there's fluid in the alveoli, which points to the possibility of acute respiratory distress syndrome, or it could be a pulmonary fibrosis. So can I just try this again to see if you could hear it? Let me know if you hear it. Can you hear the sound?
Yes.
Oh, wonderful. So it now works. Okay, great. So I don't have to go to YouTube. Okay. All right, so that's coarse. And these are fine crackles. Okay, so those are the ralphs or crackles. And of course, they're going to be either a coarse crackle or perhaps a fine crackles. The other kind of discontinuous sound is what is known as a pleural friction rub. So what is a pleural friction rub? A pleural friction rub is a loud grating sound. And this is usually heard over the lower lung lobes when there's an inflammation of the pleura, rubbing together. It is usually heard in patients with pleurisy and usually louder than other lung sounds due to its generation closer to the chest wall. Now, because these sounds occur whenever the chest wall moves, they are generally heard throughout inhalation and expiration. The lung sound is always associated with the inflammation of the serous membrane lining of the thorax, known as the pleura. Now, this sound could be confused with crackles. But how can you differentiate them? Well, you can differentiate them because they usually are going to be localized. And in addition to that, the patient will complain of pain on deep inspiration. So if you hear this sound and you're not sure whether or not it is a crackle or a row, then just observe the patient's expression manifesting pain. If the patient is manifesting pain, then it most likely is going to be a pleural friction rub. Okay? So this is the description of the pathology. There is going to be inflammation between the visceral and the parietal pleura, which means to say that they're going to be rubbing against each other. And that's exactly what you're going to be hearing. So let's take a look at, or listen to, I should say, to a pleural friction rub. Please indicate if you hear the sound. If not, we're going to go back to YouTube. Thank you. Okay, so that's pleural friction rub. So we have now talked about the two kinds of adventitious breath sounds, namely the continuous sounds. They are going to be your rhonchi as well as your wheeze. And we talk about the discontinuous sounds, your ralphs and your pleural friction rub. So having reviewed all of those, let's now go to the procedure of auscultation, because this is going to be very, very important. Now, whenever we are listening to breath sounds, what we need to remember is that we should always put our stethoscopes from one side, comparing it to another. I know that a nurse does not know the real procedure for auscultation when they put their stethoscope right here and then go down and then go down all the way there. That should not be the case. The rule of auscultation, when auscultation lung sounds, is going to be compare one side to another. So if you put your stethoscope over here, thou shalt always place the stethoscope in the same area on the other side. So thus it will be a staircase fashion of auscultation. First, we're going to put our stethoscope on one side and to the other, go down, compare to the next, and so on and so forth. So it's always going to be comparing the breath sounds from one side to another. All right. So the examination should include listening to the anterior chest, the mid-axillary region, and the posterior chest. So the posterior chest should be examined from the apex, right over here. You should put your stethoscope right on the side of the neck. These are going to appreciate the apices of the lungs, the apex of the lung. And of course, the breath sound should be assessed during both quiet and deep breathing. A full breath should be auscultated in each location. So in other words, I'm going to say, taking a deep breath, move my stethoscope over there, deep breath. This is what I often see. The patient is taking a deep breath and say, the nurse is already right over here. That should not be the case. It should be one respiratory cycle for each site so that you will be able to appreciate both inspiration and expiration, so that you could also appreciate the pitch, the intensity, the duration, and the distribution of those breath sounds. Okay, so again, over in this particular slide, it underscores the importance of listening to the supraclavicular area in order to appreciate the apices of the lungs. Then let's not forget that when we examine the patient, we always have to ask them to raise their arm. If you did not really raise their arm, then that means to say that you were able to assess the lateral portions of the heart, which are, of the lungs, which are as important as the anterior as well as the posterior aspects of the lungs. So there are several things that I'd like to point out in making sure that you do this well. And the first thing is to always ask the patient to breathe upon your instruction. So usually when you are auscultating, patients usually have a tendency to start breathing for you. And you do not want that to happen. You want that to be in concert with your instruction. So I would say, Mr. Smith, open your mouth and take in a deep breath and out. In and out. We always should be mindful that we are not going to hyperventilate the patient. So it's always best for you to have a break in between. Also, you want to make sure that you press the diaphragm firmly against the patient's skin. Ask the patient to inhale and exhale slowly through his mouth. And again, make sure that you proceed in a systematic manner, always comparing one side of the patient's chest or back with the other. You know, I skipped one slide, and that is one sound, which is Stridor. And I apologize. So let's go back to another sound, which is known as Stridor. This is a continuous high-pitched crowing sound that is heard predominantly on inspiration. The cause of this sound is generally a partial obstruction of the larynx or the trachea. Stridor may be heard in conditions such as croup, which is the most common one in children, as well as foreign body obstruction. It is typically loudest over the anterior neck, right here, as the air moves turbulently over a partially obstructed airway. So remember now that Stridor is high pitch. It originates from the upper airway and occurs mainly on inspiration. It is distinguished from other sounds by its location in the neck more so than in the chest. Okay? So this is what stridor would sound like. Okay, so that's stridor. We have now come to the end of the presentation. What I'd like to do is to conclude with an assessment before Kahoot. So let's take a look at some of these exercises. All right. So pictured over here is the patient's chest, and this one is anteriorly. And you could see where the stethoscope is located. All right. So I'm going to play the sound, and I'm going to ask you to identify whether or not it's a normal breath sound. And if it's normal, is it vesicular or bronchial, or is it an abnormal breath sound? Again, if it is an abnormal vesicular or an abnormal bronchial. So I'm going to ask you to answer this. Hmm. Oops. Okay, so here is how you answered. Let me see. A lot of you said normal vesicular. Others say normal bronchial. And another one said abnormal vesicular and abnormal bronchial. Okay, so let's consider the location of the stethoscope. So if we look at the stethoscope, what sound should we be expecting to hear in this particular area? What sound do we expect? Vesicular. Very good. It should be a vesicular breath sound. But what did we hear? So let me play that again, because you might have not noticed the intensity of those sounds. Oh, shucks. Did you hear? You did not hear any sound? So let's do it again. Did you hear it now? Okay, thank you. So let's go ahead and play it again. So if you hear it, the the sounds are equal. It looks like. So you heard the inspiration equal to the expiration, and therefore this is an abnormal finding. This sounds like a bronchovesicular breath sounds, and therefore there's a suggestion that perhaps there is a consolidation in that area. Okay, so that is abnormal. Let's go to the other one. And notice now that my stethoscope is posterior. All right, so first of all, we're supposed to be listening to vesicular breath sounds in this particular area, right? But what we heard was, in addition to the vesicular breath sounds, are going to be a discontinuous breath sound. And those discontinuous breath sounds, therefore, are going to be abnormal in those areas. And that is a row. Okay, so this is how you answered abnormal vesicular. Very good. Okay, let's go to another one. So let's say now that you have your stethoscope in the front, right over in this area. Think about what you should normally hear in this area, but this is exactly what you hear. Mm-hmm. Okay, let me repeat it again. Oh, I'm sorry. Where are we? Right there, right? All right, I'm glad to see that most of you were able to identify that this was a discontinuous sound, and it could either be a RAL or a pleural friction rub. And I don't blame you. They sound the same. But how can you make the difference between this rub or perhaps a RAL? What can you do to differentiate the two? What can you do to differentiate the two? Aha. C for the presence of pain. Very good. So if you answered plural fiction, Rob, you're correct. Ralph, you're also correct because they sound the same. But the clue here is if the patient, this finding is associated with pain, then it would be a plural fiction Rob. Let's go to another one. Let me repeat that. Ah. Okay, so first of all, what should you expect in that area? This is close to the bronchovesicular area, and therefore that's what you should be hearing. And the clue is if it's bronchovesicular, inspiration should equal to expiration. So that is exactly what 64% of you said. So you were able to identify that correctly. Okay, let's go to the next one. And this is the next one. All right. Let me just play it again. Okay. All right. So that was a wheeze. It's sibilant rhonchi. It's high pitch. Okay. So this is how you answered. And let's go to the next one. Let's see. Okay, so let me just play that again. Up. I'm sorry. That was supposed to have been a rouse, right? Okay, great. Thank you. So there are some technical issues that I had to face, so I apologize for that. I wanted to thank you for listening to this presentation. And what I'd like to do now is to see if you have any questions before we go to our Kahoot. Are there any questions that you might want to ask? If not, we're going to go to a quiz and we're going to play a game again before we go. And what I'd like for you to do is to take your cell phone and join us by going to kahoot.it. Kahoot.it or scan the QR code on the screen. And Enter the game pin 6575679. All right, if you could not join us because of technical issues, just stay online, look at the screen, and see how it's played. Okay, so this is a game to determine who has the fastest response time and, of course, being accurate as far as the answers are concerned. So you will see the questions flashed on the screen and you will be responding with your phone. Okay, so let's go ahead and get started. All right, so let's see. The diaphragm is going to be used to auscultate breath sounds. And Michelle, again, Brian, Lavina, George, and J.O. have the fastest response time. Okay, so the correct answer is you have to wet the area. Okay. Over a hairy chest, you remember you can press on the diaphragm firmly, but not lightly. All right, so let's see. Michelle, Brian, Fatima, Brian, Lavina, George, congratulations. Let's go to the next one. Okay, very good. It's false. Excellent. Remember that it's a misnomer to think, or a misconception to think, that the sounds that you hear are those that are entering the alveoli. Okay, Michelle, Lavina, Fatima, George, and J.O. Congratulations. Okay, it has 3 lobes, correct. All right. And Michelle, Lavina, Fatima, Gio, and L. And Michelle has a streak of 4. Congratulations. Okay, so it is best to ask the patient to breathe through their mouth, not the nose. And Michelle, Lavina, L, Gio, Fatima, and Maureen is the highest climber. Congratulations. Okay, so bronchial breath sounds are normal breath sounds if they're located in the normal areas. Bronchial breath sound is going to be abnormal if they're located elsewhere where we anticipate them to be. Okay, so the correct answer here is false. Let's see, Michelle, L, Lavina, Gio, Fatima, and L has the highest streak of 4. Congratulations. Okay, so if we're listening to the APCs of the lungs, these are the APCs of the lungs right over here. We should be listening to vesicular breath sounds. Okay, so Michelle, L, Lavina, Fatima, and Jaya, with L having the highest streak. Congratulations. Okay, so it should be at the edge of the sternum. All right. The neck, you will be hearing bronchial or tracheal breath sounds. So let's see who answered it correctly. Al, Michelle, Lavina, Fatima, and Jaya. And let's go to question number 9. Okay, so when a patient has asthma, they will have wheeze, and a wheeze is also known as a sibilant rhonchi. Okay, stridor would be heard in obstructions of the upper airway, so it would be located in the neck. So let's see. L is the fastest with Michelle, Fatima, Lavina, and Gio. And the last one is okay, the correct answer is none. Again, if you look over here, this is the area of the scapulae, and therefore you will not be able to listen to breath sounds in this. So let's see who the honors are. For respiratory assessment, on 3rd place is Fatima. Congratulations, Fatima. 2nd place is Michelle. And first place is going to be, let's see, well, congratulations. And an honor rolls are Lavina and April. Okay, so once again, we had finished our, what do you call that? Our presentation. And I want to thank you once again for participating in this presentation. I hope that you will be able to participate again in the near future. And what I'd like to do now is to ask you to fill in the evaluation for this particular presentation. And I hope that you had gained from it. And I hope to see you in the next presentation, which will be on Monday. So have a nice Halloween, and I will be online for the next 20 minutes to respond to any questions that I might not have been able to respond to during the presentation. Once again, it was my pleasure to be with you, and I look forward to seeing you again on Monday. Have a good day, good evening, good night to all of you. Thank you.